Hello, everyone. I welcome you all to yet another episode of Vodcast brought to you by ISCCM. I'm especially excited today about today's episode because our guest is someone I had a privilege to work with. Introducing Dr. Nicholas Barret. He's a consultant critical care in Guy's St. Thomas Hospital. He leads the ECMO program there, which has set global standards in ECMO care. He is also a specialist advisor to NICE guidelines on ECMO and ECOR, and is a founder member of EuroELSO. We are really privileged to have you, sir.
It's my absolute pleasure to be here, Monalisa. Thank you so much for inviting me.
Thank you once again, Dr. Nicholas Barret, for joining ISCCM Vodcast on ECMO. We are privileged to have authority on ECMO to be our host to answer the queries and questions what we have. So let me go straight to the first question. ECMO over the years has been evolving and evolved to an extent from the 2010 H1N1 pandemic to the COVID, and now almost every institutions are getting used to initiating ECMO. However, we would like to ask you the first question regarding the indications to initiate an ECMO. ELSO guidelines always give a value about the PF ratios being or hypercapnia being a target to trigger ECMO. So we would like to your opinion on using the driving pressures, which definitely helps us, limiting driving pressures will limit the ventilator-induced lung injury. So what is your opinion on keeping driving pressures as a criteria for early ECMO initiation to prevent lung injury?
Absolutely. Well, thank you very much, Jaicob, and thank you for inviting me here today as well. So I think indications for ECMO are really important. I'm just going to expand it a little bit, if I may. So I think the first thing is the patient has to be sick enough to benefit from ECMO. This is not for our weller patients. They have to be sick enough. And so these patients have to be at the limits of conventional ventilation. So having failed prone positioning, having high driving pressures, so really above 15 to 20 centimeters of water, which is where we think that the limit should sit. High plateau pressures really above 30, and high respiratory rate. Again, looking at respiratory rates in sort of well above 35. And it's about looking at that mechanical power that the ventilator is sort of impacting upon the lungs. And that's, of course, rate, driving pressure, PEEP as well, and absolute pressures. So it's bringing those together to a patient that's sick enough, but also a patient whose background health is well enough to cope with what's a very arduous and long critical care stay. This is not for people who would ordinarily be at the end of their lives. So for people who are in robust health prior to things, and early enough. And I think, if I'm honest, the biggest mistake that we make and clinicians around the globe make is waiting and waiting and waiting and waiting in the hope that the patient will turn around. And we know that the longer duration of mechanical ventilation prior to the onset of ECMO really does cause harm for our patients. So get in there in the first few days in patients with high driving pressures, high respiratory rates, and high plateau pressures.
Thank you so much, Dr. Nick. I think that was brilliantly answered. My next question to you is on proning with ECMO. Prone positioning has been believed to, improve the oxygenation in ARDS. And prone positioning in patients who are already receiving ECMO is believed to have some synergistic effect with the ultra lung protective ventilation. What is your take on it? And additionally, what are the anticipated issues and challenges which are associated with implementing prone positioning in these subset of patients?
Yeah, so thank you, Monalisa, for that question. So prone positioning, many of our patients who go on to ECMO now, the vast majority have been ventilated in the prone position and are commonly failing prone position in order to go on to ECMO. If we look at the recent study of prone positioning on ECMO, admittedly in a COVID population, there wasn't any particular benefit with early proning going on ECMO. I do think that there is a place for proning on ECMO. Personally, I tend to use it towards the end of the run. So at the beginning of the run, I back right off on the ventilatory pressures and we often see quite significant atelectasis, and there is an argument about whether that's the best way or not. But I tend not to use proning right at the beginning when the patient is more unstable. I wait until we're getting partial clearance, and particularly if we've got somebody who has significant lower lobe consolidation after a week or so of ECMO, I often prone them at that point in order to better aerate the lungs and to better protect the lungs in order to get them off ECMO, because clearly the longer you're on ECMO, the greater the risk of bleeding and infectious complications. So that hasn't been explored in any of the studies to date. It's very much a personal feeling, but I think that's a better place for proning than in people who've failed proning prior to going onto ECMO. In terms of the challenges, it is really challenging. It's very challenging nursing. Clearly, you've got all the problems in the prone position with feeding, with movement, with ventilator dislodgement, etc. You also then have the additional burden of the return and access cannula, and it depends on where your return is. So if the return's in the neck, for example, it's very difficult with moving the head side to side in order to better protect the eyes. If you've got a completely flat bed, so you might need a proper face rest and the body sitting higher. We tend to mainly use femoral ECMO, and so we have return and access in the femoral vessels. And what we do is our nurses redress the cannulae so that rather than lying on top of the thighs, they come down and then sit more on the medial aspect of the thigh. Under the cannulae, they put, I think it's duoderm, so quite a thick layer to protect the skin, to prevent pressure areas. And then with that approach of sort of dressing the lines medially and using a thicker protection underneath them, we don't get the pressure areas that we were getting earlier on. Once the patient is in the prone position, though, we have found that actually they are quite stable. You do need to make sure the abdomen's free. You do need to be very careful about your pressure areas, but although they require more coordination in the turning, they don't require, they're no more difficult to manage than any other prone patient.
Thank you for that clear answer and giving practical tips for managing prone position in an ECMO patient. Dr. Nicholas, I would like to ask the next question for a separate indication for ECMO. Traditionally, we use it for respiratory failure. However, we do have a lot of patients coming to us with thoracic trauma, the chest trauma, going in for lung contusions and ARDS, requiring ventilator support, not able to maintain the oxygenation and carbon dioxide levels. So what is your thoughts on ECMO initiation in chest trauma and the challenges associated with it?
Thank you, Dr. Jaicob. I think that trauma is actually a very good use of ECMO. There is almost two distinct areas. The first is major thoracic trauma, clearly without disruption of the great vessels, but potentially with disruption of the main bronchi or airway, where the use of early emergent ECMO can facilitate patient management and can allow repair of that and then protection of the patient afterwards. The other area where it's very useful is, of course, the lung protection in patients who, say, have air leaks or who've had major thoracic surgical repairs or have significant pulmonary contusions. And in that particular population, we know that pressure and power put into the lungs does cause significant injury. And so for that group in particular, putting them onto ECMO can be very helpful, and we've used that recurrently. The biggest challenge is bleeding, without a doubt. And intrathoracic bleeding, whether it relates to the chest drains, whether it relates to the lung parenchyma or the vessels, is the biggest problem that we face within ECMO for trauma. We do tend to either run very low levels of anticoagulation or indeed have the patient anticoagulation free for a period of time. And we do the same for neurotrauma as well. And we found that a successful approach. It doesn't control everything because you still get the impact on platelets, you still get the impact on fibrinogen in particular. But nonetheless, it can be a useful way of managing the patients. So we have had great success in the thoracic surgical population, particularly the traumatic ones.
Thank you for that wonderful answer. A separate indication, definitely happy to know about the success, and that is a great value point for the listeners. We'll move on to the next question regarding, a lot of centers have been started using ECMO in awake intubated patients or spontaneously breathing patients, alternate to invasive mechanical ventilation. This awake ECMO always helps us to avoid high sedation, and they will avoid the deleterious effect of mechanical ventilation. A lot of challenges are associated with managing awake ECMO patient. So can you please discuss the pros and cons of awake ECMO, the technical aspects and the challenges?
Thank you very much, Dr. Jaicob. I think that, again, there's two broad patient populations for awake ECMO. The first is patients that you never ventilate. Now, they are a very small proportion, but if we think back to the sort of patients that might be required for, patients with massive air leaks, major airway disruptions, or in whom actually intubating may well lead to their imminent death, that particular population can go straight onto ECMO. It's more of a challenge. Got to use local anesthetic. Often the patients are very panicked. They're in a degree of respiratory distress. But once they're on ECMO, then you're able to better support them. The other group is in the rehabilitating phase. And they tend to be, for our population, several weeks in. We find that the biggest challenge is getting them to a point where their delirium has cleared and they're able to comfortably manage and cope with the stresses and everything else that's going on. If I'm honest, when I've been talking with clinicians in India, I think you manage awake ECMO often a lot better than we do in the West. And I think a lot of it is down to patient expectations and family expectations of what people will go through. But the big challenge is clearly having the patient awake, having delirium cleared, having them pain-free, having them able to breathe and cough and clear their secretions, because if they can't actually clear their secretions or they've got a completely obstructed whiteout, it's very, very difficult to move them forward. So you do need the appropriate physiotherapy tools, whether that's cough assist or the use of adjuvant mucolytic agents in order to try and move that forward. They need to have few other problems. So you can't have significant cardiac problems, abdominal problems. You can manage them with renal problems. That's okay, and dialysis. The real benefit comes in with multidisciplinary rehabilitation and being able to start with in-bed exercises, move to the edge of the bed, to the chair, and then ultimately the goal clearly for walking. We tend to use it in our longer stay patients, particularly for patients where we're thinking about bridging to transplantation. And we found that prolonged period of being awake and exercising is very beneficial. The last thing I would say is what we have found, and again, it may be our population rather than a global phenomenon. We found often it's easier in patients who are femorally cannulated than with a neck cannula in, because they're more comfortable and they move less. And it means that the patient can move their head around in an unrestricted manner without having the cannula kink or move or do anything else. So, but clearly, many centres around the world happily mobilise people with either a single lumen or a dual lumen return. So that's just the way we've found things over the years.
So thank you so much, Nick. That was great, actually, quite enlightening on awake ECMO, and it is slowly becoming more and more popular. My last question to you is about organ transplantation. So basically, there's a growing mismatch between demand and supply of organs for transplant, and it's a significant concern. I have read that one of the strategies to improve organ availability is using organs from the patients who were receiving ECMO at the time of death. Can you explain how this process works and discuss the ethical, medical, and logistical concerns which are involved in using organs from ECMO-supported patients for transplant?
Okay, thank you, Monalisa. So transplant from ECMO is certainly possible, and taking organs from patients is absolutely possible, and we can fulfill patients' wishes when it comes to managing their or allowing transplantation, because we do need to respect their wishes. It depends a little on the nature of the patient's death. So when the patient would potentially fulfill declaration of death by brainstem criteria, that becomes a little more tricky, because it's difficult to tell in a patient who, say, has complete consolidation, whether that patient is breathing. You can't see whether they've got end-tidal CO2. You may or may not be able to see any muscular movement. You certainly may not be able to see any tidal ventilation. So it's very important that when you're doing the apnea testing in particular, that you are confident that whether you can actually see the detect whether the patient is or is not breathing. If you can't, you can still proceed to donation, but in the UK that would be through a declaration of death by cardiac criteria. So we would speak with the family, withdraw ECMO, allow the patient to die, and then proceed to uncontrolled donation. So declaration of death can be more difficult. It is very important that you still adhere to your national guidelines or regional guidelines for the declaration of death. We have specific modifications in the UK, which we have now got into our declaration of death guidelines, which comes out through our Academy of Royal Medical Colleges, specifically to describe declaration of death on ECMO. I don't know whether you do in India, but if you don't, it would be a very useful thing for the community to develop that in collaboration with your lawyers and government and colleges. In terms of the process of organ donation is the same. Clearly, it's still down to the individual units as to whether the organs meet the criteria or don't. We do tend to find that our cardiac transplant program are a little reluctant to take patients who've been on even VV ECMO because of the access and return cannulae often being up near the heart. So we tend to find that abdominal viscera are the ones that our local transplanters prefer, but I don't think that's for any reason other than that they're concerned that there may have been some damage to the heart, and often our patients have significant right heart strain, etc. In terms of the ethical side, I think it's really important that you're moving in lockstep with your own community. So your community, your physicians, your lawyers, your government needs to be comfortable with organ donation from ECMO, and to have the legal structures in place to facilitate that. And my view is very much that we need to give the patients the right to be able to donate if that is their wish.
Thank you, Dr. Nicholas. Barret, for that complete answer, touching upon all the aspects of a very sensitive topic of organ donation and how ECMO can be utilized. With this, we have completed our Vodcast questionnaire. On behalf of ISECM, we would like to put our deepest pleasure for joining us for this an important section on ECMO. Our listeners will be definitely benefited. Thank you and have a great day.
My pleasure, and thank you so much for inviting me. India is one of many places around the world. It's very close to my heart. I've had some lovely time in India and hope to come again fairly soon.